I would give our country a grade of a D. Every week is a 9/11 in America right now.
Hey, welcome to Unlatched Mind. My guest today is Dr. Adam Rosh. We had Dr. Rosh on back in April of this year, and we were lucky enough to get him back on for this episode. We talk all things coronavirus, COVID-19. Dr. Rosh follows the coronavirus very closely, and he has some really good information for us. So we talk about how the testing's going, how accurate some of the testing is, some of the myths surrounding testing results and the metrics that we're hearing from the media and from the administration. Dr. Rosh gives us his thoughts on how we've done as a country in response to this whole thing. Spoiler alert, it's not good. Talked about his predictions on a vaccine, and when he thinks that a vaccine will be readily available, and lastly we really touch on what his predictions are for as we get into the fall and the winter. Talking to Dr. Rosh, I think things are going to get a little precarious as we head into the winter and the flu season here. So anyway, let's just jump in. I give you Dr. Adam Rosh. So we had done this originally back in April. I think I had to look it up. It was like April 11th. I think we released it, and so that was obviously before a lot of the stuff had really kicked in. And I think I had sent you an email on this. I said your predictions were eerily accurate. And I think, and I'm not even just saying that. I mean, if you go back, at least maybe it was just me. I didn't have a full appreciation for where this thing was going to go. Obviously, you're much closer to it. So, you're kind of living, you're living in it more or less because people are coming to you for help in this area as a doctor, right? But for me, I didn't. You talked about the airplanes and every other sea, or taking temperatures, people taking your temperature before you enter a building, and masks, and on and on and on. And I was like, half of me was thinking, really, this guy's a little, I don't, yeah. And it literally it's exactly the reality we live in today. So I said, well, we got to do this again, because I'm thinking, the fall's coming, winter's coming, flu season's coming. I want to get Adam's view on what, his opinion as to where things are headed. So, I guess before we get into all that, how do you feel that we've dealt with it thus far? I mean, we have a lot of data's coming in now. I was tracking it, almost daily. Just, I don't know, one of the websites I used had it. You're just looking at that and you're waiting for that curve to sort of flatten, and then every pop up is a political left versus right thing, and you're kind of trying to ignore that, and it's just got a little frustrating for me. But overall, how do you think, as a country, we're doing? I guess 6 months in, whatever the timeline is.
Yeah, absolutely. And first, let me just start by saying thank you, Vinny, for having me on the podcast again. It's great to be on. You've been doing a really fabulous job. I've been listening to you.
Cool, man, I appreciate that.
And second off, I think, like you said, our last call was March or April, and we've had this time period, and it's good to see you're still out and about and active and doing things. Yeah. And because we're looking at a very dangerous situation right now. And, to start off with just saying, the greatest gratitude and the greatest, in awe of the people of the world, the people of the country who are dealing with this and getting through it. And I think we just, I want to start off by just saying that and recognizing our efforts as a human species to deal with this, right? Like that's really important, because people are dying, right. People are suffering, people are depressed, people are unemployed, and those things are real. And while we're here talking about this, it's important, and we seem to be, we're doing okay. There are a lot of people out there struggling, so that's important to start in recognizing. As far as how we've tackled this, I would give our country a grade of a D. And I'm going to explain this, right? And the main failure of the country is that, and what's really interesting, and this is, we have, the first of all, the fact that it's become politicized, it just leads into this failure. One thing that we know that we needed from the very beginning, which we commented on, we talked about this, is in a time of crisis, you need straight talk, you need honesty, you need to tell the truth. Now, it's disappointing to hear our leader talk about things such as I don't want to scare people, or, whatever that is. The American people deserve the truth from day one, and we will handle it. We are not going to get over worried. It's the strength of the American people, which is so amazing, that you give us a challenge, we'll deal with it. And so when you look back at 1918, another failure, and it happened to be a different party in office at the time, it was about lying about what was happening. And that led to confusion. And so here's why this is a D. Because our federal government has taken that approach, and because it has not had a centralized process, a top-down approach here, what that's left us to do is to fend for ourselves state by state. And the states are doing a good job. The communities are doing a good job, but there is no centralized message. And what happens is some people are making decisions based on good data, and some people are making decisions based on poor data. So I'll start there, in that we could have done much better. Okay, let the past be the past. What we need moving forward now is the leadership to move forward from this, and to have a unified message, and to provide the resources necessary so that we are in this together. So, I don't like to focus on what happened in February and March. That's in the past. Like, there's no point of focusing in on that. I want to see people, again, there's always an opportunity to step up and to take a leadership role and to tackle this, because we have a long way to go still. Yeah. We are in the middle innings of this pandemic. We have a situation now that we've just been through probably the best part as far as infectivity rates. If you go back, what we saw is the initial spike where no one saw it coming. We knew there was a pandemic, but we didn't understand how it was going to attack America. And we saw huge spikes in New York, and then, the rest of the country. We had Detroit, Louisiana, New Orleans, and then it faded a little. And if you go back to those stats in New York, they were doing about 20,000 a day of infections, and we thought that was high. And then we did physical distancing. We learned about that. We learned about mask use, and it came down. And then people started springtime, it started warming up. Spring was turning into summer, and we saw huge spikes, Texas, Florida, Arizona. And then we were seeing 60,000 a day, right? And now we've tackled that. And people are now believing in, mask wearing, physical distancing. And now we're at
or most. Hopefully, it's most. Yeah.
Not everyone. Well, here's what's so interesting about this. Now we're back down. We hit 40,000 a day. Right? Think about that. New York was 20,000 a day, and that was high. Now we're almost comfortable with 40,000 a day. And if you look at the inflection point, I was studying the data this morning. September 12th. That's the day that we're going to go back to. That's the inflection point for the next kind of phase of this, because you start seeing the increase in infections again. And that increase is pretty much due to students going back to school. That's going to be my guess. It's inevitable, right? Like, we know so much there is so much we know about this virus in general from the beginning. There's so much we don't know, right? But we understand transmission. So what we're going to see is it's almost inevitable. We are going to see another spike increase in infections. How high that goes, we don't know. The younger adults, right, the teens and young adults in universities, they're coming back together, and they, because the consequences of illness for them is much different than in older adults. Now, I want to touch on that because it's not
Right,
nothing.
right.
Uh, we're going to see another increase through the fall. How high that goes we'll find out. And then the winter months it's gonna, with the cold weather in the northern part of the country, in the mid part of the country, it's going to force people inside again. And this is going to be a very interesting time. We've just been through the best time, right? Where the lowest rates of infection, which is great. When you have low prevalence, you could be more active. And now, until the springtime hits again, it's going to be very interesting. So, that's at a high level. I think I think if we look at New York State has done a phenomenal job. New York State and New York City has done a phenomenal job. They have infectivity rates below 1%. And I think we need to all agree that the reason why it's like that is because people are wearing masks, and where we used to have the debate about what kind of masks, I think we solved that one. Just covering your face works, it appears.
Right.
And
Well,
being dis
let's actually, that's a
works.
good point. So I did want to clarify that because I keep hearing folks say things like, "Oh, that mask doesn't really do anything because if I sneeze on you, it's not an N90, it's not a really good mask, and the particles can go."
Right.
And I keep saying, "Well, this mask is not to protect me; it's to protect you." Right now,
Yeah.
first of all, I want to make sure that's true. Right. The bottom line is the me expelling droplets. I may have it, I may not know, and basically this cloth piece of whatever this thing is in front of my face, cloth, not whatever,
Yeah.
it's just keeping my crop dusting effect much, much, much smaller. Right? Is that basically what
Yeah.
the whole point is? I want to just fact check that first.
Yeah, so I think so, right? In that, and I say I think so because I come at this from the standpoint of science, right? In that, right, as we get more data, as we get more information, outcomes could
Yep.
change. But it seems that way, meaning the world has warned, right? The world had a spike, the world put on masks, the world distanced, and we have a drop in infections. The initial debate about KN95, N95
Mm-hmm.
aerosolized, where we once thought that this was just spread from droplets, and then perhaps it's even aerosolized, where it didn't matter what kind of mask it was still coming out. It was still spreading enough that it didn't matter if you were wearing that mask. I think what we're seeing is the covering, putting on a mask prevents droplets from entering the environment and reduces transmissibility. And it's such a simple thing to
Right.
do, and it would allow us to do so much more in our society. You've seen that. I go to Starbucks now, right? I've been getting my
Mm-hmm.
coffee. I've been doing, sports with my kids. We put on a mask, and it seems that the infection rates are contained by
Mm-hmm.
doing that.
Yeah, and of course, and I don't want to get political. Actually, yes, I do. But you have a president that won't put one on. So that doesn't that complicate things? I mean, I, I don't know. I guess we shouldn't get
Yeah.
into all that. But that annoys me. It's
No.
like, well, if the medical community as a whole says we think basically this is better than not wearing masks, they're not going to go as far as saying because the science is still probably evolving, but then I just wish the leader of our country would just do what the general medical consensus says we should do. I don't know.
Yeah, there is no question. And it doesn't have to, right? We don't have to make this political. It's like Michael Osterholm, who is the head of the Center for Infectious Disease out in Minnesota. He says his role is to call balls and strikes,
Right, right.
right? Like, let's call balls and strikes here and not worry about anything else. And yes, the leader of our country should wear a mask to demonstrate to the rest of the country that this is the right thing to do. And by not doing that, that is a failure in leadership. It's not a political, right? We don't have to
Right.
politicize that. It's a failure in leadership. The general who's leading the charge,
Right.
right? Traditionally, when we right, they're leading the
Right.
charge,
Right. Right.
right? And they have to do. They're going to do what
But
everyone else
now
is
that
doing. So
but the stance now in the country is the right thinks this thing has been overplayed and it's kind of BS. It's real. They'll accept it's real now, but it's kind of BS. The left was saying that from the beginning this is going to we have to shut everyone down forever and the government will save us. So no matter what, it has to become politicized. But just and I imagine our leadership not wearing masks like we just talked about probably I would imagine contributes to your evaluation of a D. Correct. Yeah. I mean,
yeah,
yeah.
exactly. It's
Yeah.
leadership is why it's a D. I believe in I believe in the resilience of the American people. I believe in the ingenuity of the American people. But we have a failed leadership here. We have the CDC has been politicized. That is the leading organization of infectious disease in the world.
Right.
And it's been gutted and politicized. And when you see that, that's very, very dangerous.
Yep. Yep. You can't get ground truth anywhere anymore. I mean, even prepping for this, I'm just looking and I'm reading, and now you can't, you just Google what's next, with coronavirus, what's next as we approach fall, whatever. And I'm filtering searches by anything released in the past 2 weeks just to keep it current and blah, blah, blah. And it's like, you have to, I'm like reading like, oh, interesting. I wasn't thinking that. And then I'm looking at then I say, well, I got to look at the source. Okay. It's this. Okay. They tend to be a little left leaning. Okay. They tend to be, and you can literally just see, even the information you're getting is curated by your Google searches. So, I mean, I'm getting off topic, but the bottom line is you're right. This is not just about science. It should be, but everything's politicized. So everything, everything becomes, well, what do you mean? And I can just tell when someone's not wearing a mask. I know who they're going to vote. Oh, they're voting for. And it shouldn't be that way, right? It should be like, well, the medical community thinks we should be wearing masks. Let's freaking do that because biology, science doesn't care about your political perspective. It doesn't care. It just doesn't care.
Yeah.
So anyway, it's going to be tough to keep politics out of discussion. But in terms of so anyway, you mentioned the inflection point of September 12th. So that was a week ago. When you say inflection point, are you starting to see the tick back up? Is that what you were getting at?
Yeah, exactly. So, right, I look at 7-day trailing average. So the average of infections daily over the course of a week. That's a good marker to show the kind of the velocity of an increase or decrease of infections. And so if you look at September 12th, we see an inflection point. So we're starting to get now the decline is declining, right? So where we were dropping 20% a day, 40% a day, that's getting smaller and smaller because we're adding more cases. And probably in a few more days, that net negative will end up being a net positive. And I think, right, if you look at, now, obviously this is correlative, right? It's not causative. It's that, right, what happened back 2 weeks, a week ago, 2 weeks ago, the beginning of September, kids go back to school. So what's really fascinating, though, is it's so hard to know what data, if we're getting all the data accurately. We know that testing or the reporting of testing has declined. We know that there's political influence there. I'm up in northern Michigan, and I tried to get my family tested. My daughter had symptoms, and so we wanted to get her tested. And it was so challenging.
Really?
Here we are. I'm an emergency medicine physician, a scientist, and I'm having a hard time getting my daughter tested. I mean, it was so difficult. I needed a doctor's prescription. I needed to call in, and someone would call you back. It became very frustrating. So we have to wonder what numbers are accurate, or is it worse than we really think? And the other part of this is the students in colleges, right? A lot of these students are not going to get tested because what's happening is if they're tested and they're positive, they're being put in these quarantine appointments. And right, if you're a 20-year-old, What are you going to do? You're like, shoot, I'm okay. I'm nothing bad is happening to me. I don't want to get
Sure.
tested. I'm just going to deal with this. So those numbers are going to be artificially
Right.
low, and it's going to end up having a poorer outcome. You
Yeah.
watch. We're going to see a poorer outcome. We're going to see increase in numbers beyond what we should have because a lot of the students are going to
Mhm.
drive this,
Well,
unfortunately.
on the quote unquote testing, so we have the antibody test is out there, the actual COVID test. So in terms of the actual COVID test, what type of, and I've heard this all over the place, but how accurate is this actual thing?
Uh,
Because
it's really hard to tell you because there initially when there was that call for tests when in the very beginning when there wasn't enough tests out there, the FDA kind of just opened up the floodgates and we had 20, 40 different companies put out tests that were not
mm,
rigorously evaluated and tested, and you were having sensitivities and specificities that were very poor. So um, I could tell you that it's very dangerous out there. That first of all, if you call a healthcare facility, the people there don't know what test it is most of the time. At least I've done it. I've called. They don't know. They're like, well, we send it, to
yeah.
XYZ. They don't know the test. So I could go back and look at what was the sensitivity and specificity of those tests. So that's dangerous.
So there,
I think
well,
the FDA,
actually, so I'm sorry to
yeah,
interrupt you there, but that's a really good point. So when someone wants to get a COVID test, the actual test, the actual process by which that thing gets tested could be done using multiple different like
that's right.
companies approaches.
Yeah, absolutely. Yeah, there's
Oh,
no
so, yeah, I guess
standardized
that's a good point.
test.
Yeah, that's interesting. I assumed a test is a test is a test, and but you're right. It's
No,
okay. So each one of
no.
them could
And
have different rates of accuracy. So you're getting all sorts
that's right.
of. Oh
That's
yeah.
right.
Hmm.
Yeah, and that's not an uncommon
Yeah.
thing. Like when you go to the hospital and you have, for example, your electrolytes drawn and your sodium, or you get a heart test for your troponin enzyme from your heart, there are companies, different
Yeah.
manufacturers who have different sensitivity levels and different cutoff levels. That's not uncommon. And the difference though is that the FDA has
Right.
rigorously, you've had rigorous studying of those tests. Now, in this case, because it was happening so fast, these tests just flooded the
Mm.
market. And you had Chinese manufacturers, and right, putting tests out in America, and the results were miserable. They're
That seems
abysmal.
like
So
we won't go there, but yeah, interesting.
yeah,
Yeah, that is a difference. Obviously, with multiple tests for heart enzyme, other examples you gave. I mean, you would think because there's a lot more timeline and rigor that FDA rigor that
yeah,
the tests, while different, all approach the same level of result, right? They all kind of sort of converge. Like, hey, so you can almost say a test is a test, even though it's from multiple manufacturers or companies. But yeah, in this case, that's a wild card I wasn't considering.
yeah. It's the
Interesting.
same for the antibody or serological testing as well. I went and looked at my local communities, and they do. There's an IgG, which is immunoglobulin G testing, which is that's the right thing to test to show if you have antibody
Mm,
immunity. But there's different manufacturers for that as well, and you need to pay close attention. In some places, they'll draw blood from venipuncture, right? So they'll actually get a vial of blood and send that off. In other places, they'll do like a finger
yeah.
stick, right? Just take a drop of blood, and then that's the screening. And then from there, if you're positive, you need to take blood as well. So public is probably unaware of this, and right, it's like you think you're going to get a test, you think it's the best
Right.
test, and it may not be, and that's really the
And
takeaway.
with the antibody test, that's the other thing that kind of worries me a little bit. Folks that will test positive for the antibodies, that does not mean they're now Superman or Superwoman, right? I mean, that's something that I think folks are like, I already
Well,
had it, I'm immune to it now, bring it on. Like, what?
yeah, we just don't know enough
Mm,
yet to make a clear statement about that. Traditionally, in virology and immunology, if you've been exposed, if you've created antibodies, humoral immunity, you will be immune. Okay, that's
Hmm.
traditional. That's what we know. We just don't know enough yet to make that statement, and so it's important to still maintain proper precautions, even if you've had COVID. Now, there are cases. There's about 100 cases. There's at least the case that made the news was out of South Korea, where you had an individual who initially was infected in March, and it just so happened that his blood when he was infected, his blood was taken and it was sequenced. The virus was actually sequenced, so they you were able to tell the strain of the virus. And 4 months or 5 months later, this individual was
Right, right.
reinfected, and strain was sequenced, and it was a different strain.
Hmm.
So here you have an individual who's been infected twice. So reinfection. Okay. Now, there's been, I believe, close to 100 cases like that throughout the world. And that's another reason why just because you've been infected once doesn't mean you are totally in the clear
Right.
here. You could be
Now, now
infected.
that, but that implies that this thing mutated, correct? Because that was my next question:
Well,
is what are the fears about mutation?
yeah. So here's a great way to describe this, I think, because there are mutations in viruses, things like antigenic drift and antigenic shift that we see in influenza that leads to epidemics and pandemics. In coronavirus, COVID, it's still too soon to know if we're going to see things like that, but it's probably not going to happen with COVID-19. What we do see with it, though, is okay, what people want to describe as different strains. And the way to think about this conceptually is, Vinny, when I don't know how old you are, but if we took a snapshot, and this is I didn't make this up. I heard this, and it fits. I heard Michael Osterholm talked about this, and it made a lot of sense in how you want to think about this virus. At 5 years old, you had a certain look, right? Like we could say you're Vinny, and at 10 years old, you had a certain look, but you're still the same person. At 20 years old, right, you changed how you look, but you're still the same person. So this virus, what it does is it's the same virus more or less. It's just changing over
Hmm.
time. So that's how you could consider it like a different strain. Person had it right because if we believe that this came out of Wuhan, that virus had to go from Wuhan, then it probably moved to Europe, then from Europe it moved to America, and over that course, it's changing, it's evolving, it's growing. It's not necessarily massive mutations that cause drift and shift and is going to right. Mutations, the problem with mutations is they will change how things the infectivity rate, it will change the virulence, meaning how deadly it is. We're not seeing that. What we're just seeing is, it's wearing a different outfit, right? It's grown a little. And that's happens in viruses. That's not uncommon. And so in a way that's okay, like that's good. And meaning it's not having a significant change in all of a sudden going from a 0.5% mortality to a
Right,
10%
right.
mortality. And so that's
Hmm.
important. So yes, there are different strains out there. We're right. We're pretty confident, pretty sure about that. And perhaps the consequences of those strange strains may be different for
Hmm.
different people, right? How their body
Okay.
responds to that.
And now we talked about testing, a full on vaccine. Where are we with that? And what do you think a realistic timeline is for hey, we have a vaccine, it works, and everyone starts to kind of go back to normal. I know it won't be that quick and that, but a real vaccine that shows promise, that's released, can be mass produced to the public is something I think we're all, you know, praying for.
Oh yeah. Yeah, there's great news. There's really good news coming out about the progress of many manufacturers creating vaccines. If you think about this, they started, right? I know Moderna, for example, started back in January working on this because it was pretty
Yeah.
clear that what was happening in China was going to become something much bigger. So we're 9 months into the development of this, and they actually, what's interesting is Moderna was working on this vaccine for coronavirus earlier and then stopped because, right, MERS went away, SARS went away, and but it always was in their pipeline in
Oh,
a
you're saying
sense.
before it
Okay,
became the
so
SARS-CoV-2 novel. Got it.
that's coronavirus
Right.
itself was
I
being
gotcha.
worked on
Right.
as a vaccine, and then it was just kind of set aside.
Interesting.
So there was some work already started on it. So where are we at with this? There's hopeful data in very small populations, and as we increase the numbers, we're looking at 20, 30,000 people studies that are going on now. We're going to get, good data. I think it was AstraZeneca that just had to pause one of their studies because there were some increased rates of mortality. They needed to look at what that was from, because it doesn't have to be from the virus. It could be from
Right.
something else happening as well. And I would say this, the idea of the vaccine before before the election, like, please, like, you have to separate out the politics here.
Never.
Uh, you know, uh, so if the data is robust enough to make to show that we have a safe, that's got to be number one, right? The
Mm.
level of safety in the vaccine, then right, we may have a vaccine perhaps by the end of the year. That would be really great. Now, here's the important thing. Even having a vaccine by the end of the year, the implementation of that, right? The administration of that takes months and months
Mm-hmm.
and months. So there won't be any real impact from a societal standpoint, from a population health standpoint, until at least mid 2021 to the end of 2021, because you're talking millions and millions of doses. And just remember, I believe these vaccines are 2-dose vaccines. So one dose isn't going to protect you the way it needs to. And the other big unknown is how effective are these vaccines. Remember, the flu vaccine, some years is only 40%
Mm.
effective. Some years 60 and 70% effective. If we have a COVID-19 vaccine that's 70% effective, and I think that's very, very high, I don't think we'll see it
Mm.
90%, effect. I doubt it, but I hope we do. Right? What that means is every other person who gets it is still going. It's like or every 4 people really, it's like they didn't get a vaccine.
Mm.
So, it'll be like the average, or it'll be 0%
You're
effective.
saying if
So
if the vaccine overall say 50% effective, if two people get it,
50%,
one
yeah,
one will be fine, one will be covered, one more or less at 100%. The other will be almost zero. Yeah. Yeah.
right,
Mm.
right,
Right. Right. Yeah.
on
Mm.
average, right? Yeah. So, um, the I think we're moving in the right direction, but just remember, we're going to be wearing masks. We're going to be physical distancing, for definitely another 6 months. For 3 to 6 months, I could pretty much say that's
Yeah.
happening. And I would like to see this being, as far as timeline goes, because I think a lot of people think about this. When does this kind of get back to some sense of normalcy? I think 2021 is the year
Yeah.
for sure. I think we have enough information to say that by the end of 2021, things should be looking better. And I hate putting myself out there on this, and things could change, right? Like data could change, but it's looking that way. And I hope by summer 2021 that that we've made some real progress in lots of areas.
Hmm.
Yeah.
Yeah, that's promising. I mean, we've made it this far. Yeah, my uninformed kind of opinion would be also, yeah, I feel like this fall and winter is going to be rough. It's going to be a little rough, right? It just makes sense, and it's pretty much seems to be confirmed by what you're thinking. And then we start to go
Oh
through
yeah.
people are outside again, warmer weather. We've had more time
Yeah.
for the science to evolve. I think that's, yeah, if we can if everybody can just get through the winter, that'd be good. Now,
Yes.
yeah, so the other thing I'm thinking is what kind of, concerns me a little bit is, with the fall coming, with everyone starting getting the flu, everyone sniffling, coughing, sneezing. I'm wondering what it's going to be like where, because even now I'm at Home Depot and someone sneezes or coughs, you're like, dude, come on, can you back up a little bit? And it's the middle of the summer, and it's not nearly as prevalent as come October, November, when you start to get those 20, at least whatever, around me it's 20-degree nights, 30-degree nights. It's probably colder where you are. People start to get sick, and the flu, and do you see? I guess the question would be, people, do you feel like the system's set up for the quote unquote, onslaught of people that would normally be, entering their healthcare facility, urgent cares, hospitals because of the flu and whatnot. But now I feel like that's going to happen as it always does. Plus, I feel like there might be a small element of, I don't want to say panic, but folks being extra, extra worried about the fact that they're sick. Is the system set up for this? I think inevitable spike there, or do you not think there will be an uneven spike?
Yeah, those are really great points, and there's a lot of unknowns here. And I could tell you what we do know. So right now, the Southern Hemisphere starts their influenza season. And what we're seeing there is low levels of influenza, which is really, really great. We don't know why that is, meaning some people attribute that to mask wearing and COVID precautions, and it may
Hmm.
be that. That may be right. But we don't know because there are also places that in the Southern Hemisphere that are having high rates of COVID-19, but still low rates of influenza. So that doesn't make sense. That's
Hmm.
not logical, meaning that it's not because of
Right.
mask wearing. So whatever the reason is, we don't need to figure that out right now. The good news is that it's low. And that usually translates into the type of season that we see here in the United States and other populous countries in the
Hmm.
Northern Hemisphere. So that's really good. Okay, now, as an emergency medicine physician, I could recall multiple years of, high influenza rates, and it would overwhelm our system, not like what COVID did back in March, but it would bring us to capacity, and it was challenging. It was a challenging work environment. Now, we're going to be in a situation where we don't know what influenza is going to do with COVID. So let me give you some examples. Perhaps it actually reduces COVID infection. Is it possible that if someone gets co-infected, that influenza, we've seen this with influenza before, where there's different strains of influenza and one kind of subdues the
Okay.
other. And it's possible that we may see that with COVID, who we don't know yet, co-infection. So maybe we have overall a lower rates come this winter. But on the other hand, influenza itself is very similar to COVID. And if we have increases in COVID, we have increases in influenza, we're going to see a healthcare system that may be pushed to capacity again.
Yeah.
And that is why, if we remember, the whole reason of sheltering in place and to flatten the curve, it's for that. It's just not to overwhelm the healthcare system. So our public health authorities are going to be watching the number of infections and the number of people showing up at hospitals and hospital admission rates so that if it gets too high again, we may have to shelter in place again. Like that's what's happening in
Hmm.
Israel right now. In Israel, the country is shut down because their rate of rise was concerning, that they were going to start overwhelming a hospital
Right.
system
Right.
again. And That's a great approach, right? Like, there's no need to shelter in place if we don't have to, but when we have to, let's do it. Because then you're talking, right? We've had these discussions before about why
Mm.
we need to do it. So, influenza, it's going to be, we just got to take it day by day. And I think the other thing that's actionable that we could talk about is getting your influenza vaccine and when to get that vaccine. And I would say normally I wait until November, December to get my vaccine simply because the peak of influenza season is usually in the late winter, early spring, right? February, March, and the vaccines
Mm.
wane. And so I always want my vaccine to kind of be most robust at the peak of
Mm.
influenza season. Well, this year that's going to be much more challenging because hopefully we have a lot more people who will get the influenza vaccine. Because if we could suppress influenza, that's going to give us a much better ability to cope with COVID. And so I think people should start getting their influenza vaccine around now, September, October, so that there's the ability to distribute that all throughout the winter months, and that when you do go to, so that if you are protected from influenza, or relatively protected,
Yeah.
that we could
Right.
focus on
Right.
COVID.
Yeah. So the flu thing just, and this is the last big point I want to touch on. I think that so basically, again, the political side of things, you hear, well, more people die of the flu, blah blah blah, not as big of a deal. All that aside, but that is a narrative that's out there. But all that aside, the so what to the whole thing is, okay. We have there's all sorts of viruses out there, all sorts of bacteria, all sorts of things that we could get. But the only way it really matters is if it poses some ill effect on us as people, we get sick or we die, right? Because if it doesn't do anything, do we really care? Obviously, that's a gross over exaggeration and probably makes any doctor listening or biologist just squirm. But that's my layman just kind of analysis of the thing. So what I'm getting at really is how actually deadly is this thing, right? In other words, do you think now? Obviously, there's reasons to do certain things that we've done. You got to flatten the curve so the healthcare systems don't get overrun. Because if they get overrun, then unnecessary deaths occur because they can't tend to people they otherwise could. Right? That all makes logical sense. No thinking person could, I would say, deny that. But the other thing is, in terms of death rates, in other words, is it really just the folks with with preconditions, elderly, some sort of they're compromised in some way. I know there are some very healthy people that have gotten it and actually had some really bad effects, but those rates are super low, I think. But generally speaking, because what I'm getting at is, where do you stand on herd immunity? At some point, do we just let us, is there a time when we should just start, being expected to actually, we're all going to get it, so let's move forward?
Yeah, Vinny. So I totally understand where you're coming from there, and I think this is a really hard thing to comprehend and to think about here. And there's so much to unpack, and I'll do my best here. So first of all, we're looking at mortality rates probably around anywhere from, half a percent or so, 1% down to half a percent or 0.1%. It's still much, much more than influenza. So that's first of all important to know. We're how many months, half a year into this, and the number dead in the United States is way past any recent influenza epidemic. So people will sometimes throw out the Sweden model, and they'll say, "Hey, look at Sweden. Maybe we should do that." Who really didn't clamp down, and a couple things you're going to see there. Their mortality rates were high in the beginning, and they've pulled back. But what we're seeing in Sweden is just give it more time. just like California back in March, we weren't seeing high infectivity rates, we weren't seeing high death rates, and then all of a sudden
Yeah.
California spiked. In time, it will all even out. All right, that's important. But when we think about, should we all just kind of use, natural selection out here and, just get it and reach our herd immunity faster? I would say we're better than that as a society, right? And we should be thinking, right? We have the means to
Mm.
address this. And if you think about, I don't want to, this isn't the same, but I want to just highlight this in that, and then I'm going to touch on one other point here, but 9/11, right, the outrage of that act and the response of America and the world from the killing of approximately 3,000
Mm-hmm.
Americans in our country, 3,000 Americans. We lose in 1 week. Every week is a 9/11 in America right now.
Interesting.
Think about that. Every week is a 9/11. And we would never ever say, well, we have a terrorist attack once in a while. That's fine, right?
Right.
We've done everything we could to prevent another terrorist attack. So why would we take a different approach for COVID-19? And the other part of this that is not so obvious is that this isn't binary, meaning you live or you die. There are long haulers. Long haulers are people who have been infected who don't die, but who have complications. Right. And how long those complications last for are unknown. This is now going to be the next kind of area that we all need to focus on. And this is impacting the healthy people. So if you're a college student, this is what you need to pay attention to. Yes, it's unlikely you're going to die, but will you have chronic fatigue? Will you have carditis? Will you have pain when you breathe? That's what's happening right now. Will you have some autoimmune disease later on? That's what we're seeing right now. And the fact that we just don't know everything about this virus as we need to is all the reason why we need to be cautious and limit the transmissibility of it. And we will reach herd immunity one way or the other. Hopefully it's with a vaccine, right? That's the safest way to do that. But if we could just make some small adjustments in our society, if we could just put on masks and physically distance, we could come really close to going back to the way that we once were. But we know that the future will never be the same, but it will become very close to that. There's small changes that we need to accept, and we could do those things. And by doing those things, we will save lives and we will reduce the complications and the long-term impact, which then will increase healthcare costs, will reduce, right, the number of people who could work because they have some type of disability. There are so many second-order effects that will come from this virus that it's so much more than, am I going to live or am I going to die, right? The simple butterfly effect of this virus, we have no idea what it will lead to. And so let's do our very best as a society to contain it, to deal with it, and to do what we do best, which is think about creative and use our ingenuity ways to take care of one another and to be a leader in the world. And that's what I want to say.
You obviously don't work on Capitol Hill, sir. No, well said. And I think that was a great, that was sort of a great closer too. No, I really think your point about this not being binary is something I never considered. You're right. Whether or not you die or not is not the only consideration. Those other concerns, those other long-term health implications are not, they're not insignificant. I mean, that's a good point. I really appreciate that point, because I try to take a lot of good tidbits, especially from folks like you to when you're in those hallway conversations with folks that drop these one-liner politically charged opinions, it's good to just have a nice, soft response that's based on science, and and I think that's a good one. I'm gonna keep that one in my holster. So, so I appreciate that. But Adam, how's so in closing? I guess how's Rosh Review going? What else you got going on that folks should know about?
Yeah. Rosh Review is software for education of medical students, residents, nurses, PAs, and during COVID-19, what we did was we ended up making this platform totally free for all learners and students, simply because we did not want another level of stress in that community, because people were still taking licensing exams and in their training programs, and we wanted them to still be able to get the information and knowledge that was required of them to complete their training courses. And so we opened it up, and I feel real good about doing that. And we were able to kind of contribute to the response during that peak in COVID in March and April. So that's now we're just trying to continue to support healthcare workers, and we're proud of what we've done, but more importantly, the amazing work of the healthcare workers of that establishment has been hands down unbelievable.
They're currently the heroes of our society, for sure. Yeah. Amen to that. Yep,
absolutely.
Well, Adam, thank you so much. Appreciate your time. Have a great rest of your weekend. And thanks so much, man. I appreciate it.
Okay.
All right. Thanks, Adam.
You bet. Talk later. Bye-bye.